Good evening. So as Eileen said, I am currently the chair of neurology. I've been at UCI for 19 years and have had the pleasure of working with a lot of the scientists here, but I'm primarily a clinician. That's what I do. I see patients, I take care of patients. And one of the diseases that Dr. Goyal and I focus on, along with Dr. Kak, who's also in the audience, who's one of our faculty members, is Lou Gehrig's disease, or ALS. And what I like to do is maybe spend the next 10 minutes just setting the stage for Dr. Goyal's talk to talk about what Lou Gehrig's disease is or what ALS is on that. So this disease is named after Lou Gehrig, who was a baseball player. In the 1930s, he played for the New York Yankees and died of this disease within 3 years of diagnosis. He was diagnosed at the Mayo Clinic, and he voluntarily benched himself because his RBI was falling, and he knew that there was something going on with him. It has since become the disease is associated with his name, at least in the US side where baseball is played. For those of us who come from the rest of the world, and at least the colonial side of the world, we think of this disease as David Niven's disease. For those, most of you guys are too young to remember David Niven, but David Niven was the original James Bond. He played the character of James Bond in Casino Royale. He was an excellent actor, a true gentleman. But he died of ALS. And the Motor Neuron Disease Association in the UK is housed in his original residence, which was donated to the Motor Neuron Association. But the disease was really discovered back in 1870s by Professor Charcot, who's the gentleman in the middle, if I can identify. And Charcot was the first professor of neurology in the world. He was a brilliant clinician, also a brilliant anatomist. And what he did was invented this discipline of where you would look at the pathology alongside clinical aspect. And he described some of the cardinal features of the disease. He coined the term amyotrophic lateral sclerosis, suggesting that the muscle wasting, muscle atrophy was related to a damage to the spinal cord or the lateral column of the spinal cord on that. Now, ALS, fortunately, is a rare disease. Because we are a tertiary care center, we get referrals from all over the county, from all over the region, and other neurologists send us the patient. We tend to see a fair amount of this disease, but in a regular clinical practice, it's a relatively rare disease. So just to put it in perspective, we see about 170 cases a year, which in the scheme of things is actually pretty big. And it allows us to focus on delivering high quality care and provide research for these individuals. So it's a progressive disease. This disease, unfortunately, progresses and continues to worsen. And it's a fairly relentless progress. It doesn't stop. Despite our best effort, despite our treatment, this disease continues to progress and eventually will lead to death of the patient. That it's an asymmetric disease, which means one side is usually affected more than the other. And there is a concept in ALS, but it's also now we know it happens in Parkinson's, now we know it happens in Alzheimer's disease, there is a regional spread. So the disease goes from one portion of the nervous system to the next portion of the nervous system in a contiguous fashion on that. And that's a new concept that has really changed the way we thought about some of these neurodegenerative changes as well. Typically, it spares the eye muscles, it spares the sphincter muscles, so those are usually not involved. But we know from the Japanese experience where these patients are kept on a ventilator, artificially ventilated for many, many years, that these muscles may also get eventually involved as well. The average survival in our clinic is about 3 years. From the time that these patients come to see us and get diagnosed, they on average live about 3 years. Now, there are tremendous variations. There are some patients who crash and burn in 9 months. I've had patients who came to see me for the first time, told me that they had a family history of it, and most family members live 11 months, and 11 months later, this gentleman was gone. Okay, but then I've had patients who have lived 23 years. So there is a tremendous variation in this disease as well. We still don't fully understand the disease process. We still don't fully understand the pathophysiology of it. At this current time, there is no cure for this disease. In fact, we can't pretty much stop the disease at this point. All we can do is to maybe slow down the disease some. So there are drugs that are approved, like riluzole or edaravone, that provide a very modest benefit in terms of slowing down the disease. It's usually not appreciable in individual cases. So it's statistically, if you look at 100 cases, you will see some change, but not on an individual basis. And despite the small number of cases of ALS in the country, it is an area of very active research and reasonably good funding. And the big pharma, luckily, has finally started paying attention to it. So there are a number of companies like Biogen and Regeneron and other companies who have taken an interest in this disease. The disease is rare. Its incidence is probably at the same level as Parkinson's disease, about 2 in 4 in 100,000. But unlike Parkinson's, where patients live a long time, or at least 15, 20 years, in ALS, because they die in 3 years, there's no prevalence. You don't build up a prevalence. So if you look at the prevalence is only about 5 per 100,000 as well. It is somewhat more male predominant, so you'd definitely see more male cases than female cases on that. And it's usually a disease after the age of 50, although in our practice, we've seen all sorts of patients. So my youngest has been 16 years old. We've had many patients who were in their 20s. And 30s. So again, we do tend to see older patients, but we also see very young patients as well. It's also very unusual after the age of 80. So if I see somebody who looks like ALS after the age of 85 or 80, I would question the diagnosis, not that it cannot happen on that. Again, when we see somebody before the age of 40, we tend to get concerned about inherited or genetic causes for ALS. And about 10% of Lou Gehrig's disease or ALS is inherited. That means that there is a defined genetic mutation that you can assign this disease to. That we don't know the reliable risk factors. Some individuals are more prone to this disease. We know that male gender serving in the military may predispose you to a higher incidence of ALS. For some reason, professional Italian soccer players had a higher tendency. We know there is a higher tendency in contact sports, especially NFL. Okay, and to the point that NFL is investing money to figure out why that happens. And that the disease has been known for over 150 years. So that's when Charcot first described. But the real first breakthrough happened in 1993 when the first gene, the SOD1 gene, was described by Rosen and Tipu Siddique. And in fact, Tipu Siddique is going to be speaking here on Friday in the Department of Neurology Grand Rounds on that. And then the discovery of C9orf72 gene, which is the commonest gene mutation in ALS that accounts for about 43% of all familial forms of ALS on that. The first treatment for ALS was the riluzole that was discovered in 1994. It got approved by FDA in 1994, and it took another 20 years or 20 plus years before edaravone, which is the second approved drug for ALS, was approved last year or a year and a half ago. Diagnosis of ALS is pretty much still a clinical diagnosis. You can't do an MRI, you cannot do a blood test other than the 10% that have genetic forms. So this is where neurologists will always be important, because you have to take a history. You have to sit down with the patient, figure out what the symptoms are, figure out what the exams are, and suspect that they have ALS. And then most of the testing that we do is to rule out all other possibilities. So there are diseases that may look like ALS, and that may be a little bit more treatable than what ALS is. So our job is to make sure that we haven't missed any treatable condition, okay? But at the same time, also support them during this diagnostic and treatment phase of it as well. So as I said, 10% of them have a genetic cause, and that's easier because you can do a blood test to know exactly what mutations they have. But the other 90%, you're still pretty much doing good old detective work. When you take a history, you try to make sense of it based on that. It's a disease of the upper and lower motor neuron. Upper are the nerve fibers that come from the brain into the spinal cord, and lower motor neurons are the motor nerves that start from the spinal cord going into the muscle. Okay? For a diagnosis of ALS, you have to have evidence for both upper motor neuron and lower motor neuron involvement. And there are ways clinically, bedside, that you can do that. So you can make a bedside diagnosis, you can examine the patient and have a fairly good idea that that's what you're dealing with. And again, we would do testing just to confirm it, but also to rule out other possibilities as well. One of the concepts that has evolved over the years is we used to think of ALS as one disease. Okay? And the same thing is happening in Alzheimer's, the same thing is happening in Parkinson's disease, and a number of the other neurodegenerative diseases, is that these are not monolithic disorders. They are not one diseases. They are probably a combination of multiple different diseases that eventually look the same. Okay? So some patients may have familial SOD1 genes, some may have C9orf genes, some may have FUS gene, and some of them have genes that we haven't discovered yet, but eventually they all look the same. And that's the concept. And that's a similar concept in the disease mechanism. Okay? The ultimate result of all of this is that your motor neurons die and you have cell death. But that cell death may happen because you had mitochondrial damage and your body didn't know how to react to the free oxygen molecule that gets produced when we eat food or when you do things. It may be related to protein misfolding, how the body or the cells handle the abnormal proteins that are created because of mutations or because of other reasons. It could be because of excitotoxicity, which has been probably the most popular hypothesis for ALS. But the end result is you have cell death. And that's what we're trying to prevent. We're trying to prevent cell death so the disease doesn't progress. And that's what we're trying to regenerate with the cell-based therapy or the stem cell therapy. Now, at this point, the type of stem cells that we use cannot regenerate cells. They can support cells, but they cannot regenerate cells. Okay? For regeneration, you need to use things like embryonic stem cells or fetal stem cells that have a more lineage capacity, a more reproductive capacity, but they're a lot more controversial at this point. Also, we are discovering more and more about the genetic forms of ALS, and this is just an exponential increase in the number of genes that we now know are associated with ALS. Okay? And you can see that from 1994, when SOD1 was discovered, now there are over 20 genes that we think are associated with ALS at this point. And then so what's important is that these patients who have been diagnosed with ALS get to a specialized clinic where they get provided multidisciplinary care. And what I mean by multidisciplinary care is, in addition to seeing a neurologist, they get seen by a physical therapist, they get seen by a speech therapist, they get seen by a social worker, they get seen by a respiratory therapist, but also have access to a pulmonologist, have access to a cardiologist, have access to a gastroenterologist, and a social worker. And it's been shown over and over again, this is data coming from Ireland, but we have similar data from the US, that patients who attend a multidisciplinary care clinic do better than patients who just go to a regular neurologist or a regular physician's clinic on that. And that's true for all ALS. That's true for bulbar ALS, where they only get affected in the throat muscle. And this effect is above and beyond the benefit from taking riluzole, which most clinics prescribe. So there's something unique about multidisciplinary care where you take a holistic approach to the patient and have them seen by the rest of the team that provides this benefit, and it's not just related to the neurologist or the drugs we prescribe. So at UCI, we have a large team which takes care of it. We have a number of physicians that see patients with ALS, including Dr. Habib and Dr. Kak, who are sitting in the back, and Dr. Wong, who runs an ALS clinic at the Veterans Administration Medical Center in Long Beach. We have a pulmonologist who sees these patients. We have surgeons who can do surgeries and things. We have a dedicated physical therapist team. We have speech therapists who take care of their communication issues, their swallowing issues, We have nutritionists and social workers. And then there are two organizations, the Muscular Dystrophy Association as well as the ALS Association, that provide support for these patients. All of this is time consuming, and an average ALS patient takes about 2 hours of time to be taken care of. Obviously, the insurance companies don't reimburse you for 2 hours. So a lot of this is altruistic work, okay, has to be supported. And again, most of these clinics do depend on sort of resource development or fundraising to be able to provide this care, but it's an important care that needs to be done. So I'm gonna stop here. I'm gonna stop with this beautiful picture of the Yokohama Harbor from my trip to Japan for an ALS conference back in 2006. And I'm gonna introduce Dr. Namita Goyal, who's the director of our ALS clinic, ALS Center. She is an associate professor of neurology and a really dynamic figure when it comes to ALS and neuromuscular disease.
Thank you for being here tonight, and thank you for having me. As Dr. Mozaffar said, I am one of our ALS doctors at UC Irvine, and I really came here to UC Irvine to help with our ALS care and really to further our research in ALS. As you heard from Dr. Mozaffar, ALS is a terminal condition. Currently, there's no effective cure to stop or reverse the disease. And I will say that times are changing right now. Let me just see it. Pencilus. So I went to the International ALS meeting this past December, as I annually go to, and we were talking about the number of therapies that have been tried in ALS. Since 2007, there have been over 80 drug trials done in ALS that have failed. But we really believe that times have been changing. And currently at UCI, this is the most amount of clinical trials we are doing in ALS. One of them is stem cell therapy. And doing research in ALS gives hope to these patients, which I really think is an empowering thing for the patient. One of the challenges that has happened in ALS treatment is that we believe neurodegeneration is really multifactorial. We still don't have an exact cause for ALS. So it's sort of, how do you treat a disease where you don't know exactly what is causing it? We believe that it is actually a complex interaction between cellular and molecular interactions, and potentially that there's a disruption in growth factors, there's inflammation in the spinal fluid that can cause neurodegeneration. So there's this whole new concept of thoughts, and maybe we have to use different drugs, just like our chemo colleagues, where they don't just use one therapy to treat cancers, but they use several chemotherapeutic agents to target the different pathways. One of these therapies is stem cells, and what I just want to briefly review is this is a diagram of our healthy nervous system. So the motor neuron lays, as Dr. Mozaffar explained, in the brain and in the spinal cord, and it sends off a nerve or an axon to connect to the muscle in which the muscle contracts. It's also surrounded by supporting glial cells, which is supposed to keep the environment healthy, reduce inflammation, and allow the neurons to grow and regenerate as they traditionally do. But what we believe is happening in ALS, this is the nervous system of an ALS patient, is we believe that there's a compromised blood-brain barrier, and in turn, the growth factors and the glial supporting cells die out. So the environment starts to get sick, and potentially the motor neuron cell body dies, which then, as you can see, the nerve retracts from the muscle. And so patients experience muscle atrophy, muscle weakness, and this spreads throughout their body so that individual skeletal muscles in their arms, their legs, their speaking, their swallowing muscles all get affected. What we're hoping with stem cell therapy is we're using these stem cells as a vector, basically, to release growth factors back into the spinal fluid so that we can reduce inflammation, support the glial cells again to promote a healthier environment and promote an intact nervous system so that the nerves, like Eileen was saying, can regenerate and a vascular supply or a blood supply can keep the environment healthy. That's what is postulated basically in stem cell therapy, just to keep it simple. So in ALS now, there are overall 3 major stem cell trials that have been either started or tried. And I just wanted to briefly mention the neural stem cell trial, and there is a stem cell trial that's being done at Cedars-Sinai. Both the first 2 trials take a very similar approach in that they use stem cells from a fetus, from an embryo, and they transplant it back into the patient's nervous system, into the spinal cord. But because of that, it's a surgery, and patients, because it's stem cells from an embryo or another person, they have to be given immunosuppression, just like an organ transplant. Just like if you get a kidney transplant, you have to get immunosuppressed, meaning steroids and some chemotherapeutic agents. So these 2 trials have used a different concept for delivering stem cell therapy. What I want to focus on is the BrainStorm trial for 2 reasons. One, because we're doing it right here at UC Irvine, and it has actually been the furthest along in stem cell therapy for ALS patients. So briefly, just to go through the different phases that you see I have listed. Phase 1 usually means that a trial is being done first in humans, purely to see, is it safe for the patient? Are we giving a drug that's going to cause harm? Are we going to grow a tooth in the spinal cord? Because what are these stem cells growing? Are we going to grow tumors? So the FDA makes you do a safety analysis just to make sure it's safe. It's usually done in the smallest number of patients, so N equals 12. There were 12 patients that were done for the phase 1 study. It was deemed safe to proceed. So BrainStorm then did a phase 2 study. This was done in 48 patients, and they saw that stem cell delivery was not only safe, but it may be effective in slowing down the ALS progression. So this is when the FDA said, yes, you should move on to a phase 3 study, which is only being done in the US and only at 6 centers in all of the US, which I'll talk about. And what's different about this study as opposed to the top 2 stem cell trials is that this is using the patient's own stem cells. So unlike what I talked about where Neuralstem and Cedars are using stem cells from an embryo, these are stem cells that are being taken from the bone marrow of the patient themselves. And so because of that, it's not considered an organ transplant, and patients don't need immunosuppression, which sometimes can make patients very sick when you give them chemotherapy type of agents. So I just wanted to briefly give you an overview of where we're at, because this is really quite an exciting trial, and we have had patients from all over the world contact us to want to be a part of this trial. BrainStorm Cell Therapeutics is the company that is doing this trial, and they've been in drug development since 2007. And they've been in the clinic since about 2010. We started the phase 3 study in the fall of 2017, and we're hoping to complete the study by next year. So I hope by next year, around this time, we'll be talking about closing the trial. But here's the basic concept of what happens in this trial. the stem cells are taken from a patient's bone marrow. So a needle is injected into the patient's hip bone, which our hematologists, our blood specialist doctors are doing. They retract the bone marrow. The bone marrow then goes to City of Hope here in LA, where BrainStorm, the company, has set up a lab to basically help retrieve these stem cells out of the bone marrow. They expand them, they differentiate them, they basically treat them with their product Neuron that is thought to release the growth factors when we deliver it back into the patient. And the way we deliver it is there's no surgery, there's no cutting open of the patient. We actually take a fine needle, just like a spinal tap is done, where a needle is injected in between the bone vertebrae of the spine, and a spinal fluid is identified, and the stem cells are injected back into the patient. So, and this procedure takes just minutes. Here are some of the effects that we hope the stem cells will have for these patients. It's thought that basically these growth factors will promote nerve regeneration and help improve the blood supply back into the area of the blood-brain, the spinal cord, the brain. It's also thought to reduce inflammation, and I have some results from the phase 2 study that I wanted to share with you. So this is the phase 2 study. So the earlier trial had 48 patients, and they were only done at Mass General, the Harvard Hospital, Mayo Clinic in Minnesota, and another hospital in Massachusetts. At that time, patients were followed for 3 months prior to receiving the injection. And the reason for following them is because, as Dr. Mozaffar mentioned, ALS is a pretty rapidly progressive disease. So every few weeks, patients will notice a functional decline. And in the clinics, we have an outcome measure we use called the ALS Function Rating Scale, where it's a standardized score, and we can grade the function of ALS patients. So what was determined in the 3-month period before transplantation occurred was patients' rate of progression. Then a single injection was performed, you see, at visit 5, and patients were followed up to 6 months to see if their rate of progression had changed. Safety is also very important when you're doing clinical trials. We always believe in doing no harm, right? And so what the safety analysis showed was that there were no serious side effects from giving stem cells to these patients. There were no hospitalizations from side effects. And at most, the side effects were graded as mild or moderate. This is a complicated graph, but the point of this graph, I'm going to point your attention to the left side of the graph, where they basically evaluated patients that had a rapid decline in their ALS function, and then they compared how their ALS function was graded after they received treatment. So the blue are patients that received the stem cells, and red were the patients that did not receive stem cells. They were given a placebo. Most FDA trials in ALS require a placebo arm just to compare how the two patients groups do. And what you can see is at 24 weeks, many of the patients that received the stem cells had some degree of a slowing in the rate of progression, but you see no one in the placebo group made it out to 24 weeks in terms of an improvement in the rate of decline when you compare pre-treatment to post-treatment. So that's a pretty striking response. Having done ALS clinical trials now for almost 15 years, we generally never see this data. Almost all ALS trials fail at phase 2. Very few make it out to phase 3 meaning that there's some signal going on. What's also interesting is when they looked at the spinal fluid, so the top line are patients that were treated with stem cells. The bottom line are patients that just got placebo. And they actually looked at their spinal fluid and said, well, what happened to growth factors? Did they actually have growth factors that increased? And what you can see, blue now represents the patient's pre-treatment, and green represents the patient's spinal fluid after treatment. And you can see that the patients that received stem cells all had a significant increase in growth factors. The green bar, the blue bar is pre, the green is post, so an increase. But in the placebo group, you really see no increase in the green bars in comparison to the blue bars in their growth factors. I hope that makes sense. Another very interesting finding was the inflammatory markers. So another idea or concept is that there's increased inflammation in these patients' spinal fluid in ALS that may be causing some damage. And some of these markers are inflammatory or inflammation markers. And what you see is that the patients that got stem cells had high levels of inflammation pre-treatment, or the blue bars, but in the green bars you can see a decrease, especially in the areas I circled, in the inflammatory markers, but you don't see any significant change in the placebo group. So we are hoping, we still don't have great biomarkers to tell us what does this mean in ALS, but we certainly wonder if it means something when you see data like this and you look at the placebo groups and see no change. The FDA also agreed that there seems to be a signal here, which is why we moved on to the phase 3 study. And so, like I mentioned, this has been going on since 2017, and UC Irvine is one of the 6 sites. Us and our colleagues at Mass General, the Harvard Hospital, have really been the top enrollers in this study and actively trying to find an answer for our patients. What's different about this study in comparison to the phase 2 study is instead of 1 injection, patients are now getting 3 injections. The FDA, whenever you do a clinical trial, wants to make sure, was drug delivery okay? Was it safe? Because the phase 2 data had very little serious side effects, they said, yes, do it, and maybe even do 3 to see if it's got a lasting effect. So the trial is still going to be 6 months post delivery, but every 2 months, up to 3 times, patients are going to get a stem cell injection and have been getting. There is still a run-in period of 3 months where we follow patients before the study starts to see what their rate of progression is and can the stem cells either slow down their decline or can it even improve their decline. So there are some specific criteria that we use to enroll patients, and mostly these are patients that have really rapidly declined before the study started, because we want to be able to see if we can detect a change within a short period of time. We are now over halfway enrolled, and there was a safety analysis done for the phase 3 current study done in August, which the Data Safety Monitoring Board said, yes, it's still safe, and keep going on. And we're hoping to complete the enrollment this year with the study and completely finish the study by next year and have results. What's really been exciting is not only has this trial been, at several angles, been hopeful for our patients. One, stem cell therapy is a completely different way of treating ALS that has never really been done before. It's brought a lot of attention to raising awareness for ALS. There's been several times The Orange County Register and the LA Times have done news articles on our participation at UCI and this trial. And I just wanted to briefly mention that this is one of many other clinical trials we are now doing just in ALS that I lead. And it just makes it a very exciting and optimistic time for our patients, because if you remember in my first slide, I showed you that complex diagram of all the different causes of ALS. Many of these drugs are trying to target some of the different pathways that I showed you that are responsible for neurodegeneration. So I just wanted to end with a video. ABC News a few months ago interviewed us at UC Irvine because they were really impressed with the stem cell trial. And they interviewed one of our patients who participated in this trial. And I wanted to show you guys the hope that it brought him.
45-year-old Eric Schwarz has lived his life focused on his family and his job in fitness.
Can you make a muscle? Don't let me pull.
Now, physician visits and his fight with ALS or Lou Gehrig's disease fills his mind. His motor neurons are quickly dying off.
There was no treatment, let alone a cure. I mean, there's just nothing.
And within 2 to 5 years, they lose the ability to move, to speak, to swallow, and eventually breathe.
I remember going to appointments and hoping it was cancer.
Shortly after his diagnosis, Eric learned about the ALS BrainStorm clinical trial at UC Irvine. Dr. Namita Goyal is investigating a therapy engineered from a patient's own harvested cells.
These stem cells then secrete growth factors to promote motor cell regeneration, reduce inflammation, and the idea is that their motor cells can live longer.
Stem cells are taken from a patient, brought to a BrainStorm lab where it's specially treated and injected back into the patient within a month. That'll happen 2 more times over the course of 28 weeks.
We've enrolled you in a clinical trial.
A month after his first injection, Eric noticed improvement in his hands.
I looked at my wife and I said, this is incredible.
UCI researchers, along with 5 other centers, want to enroll 200 ALS patients in this phase 3 trial.
It's empowering to have hope, both for the patient and the physician.
The details are on our website at abc7.com.
It's a long shot, but man, it has changed, honestly, how I get up in the morning.
So you heard it. This trial has really brought blood, sweat, and tears to the patients. It's a hard clinical trial. Every patient has to do 7 spinal taps. But Eric, I think, said it best, where, he can wake up in the morning because of this trial. And that hope has really been empowering for him. I really want to thank this trial was not easy to even start up, and there's been several teams that have been involved, especially our neurology clinical trial team, who you see here. Dr. Nelson from hematology has been doing all the bone marrow aspirations. He's really been a tremendous help. Initially, we were going to have several hematologists that were helping, and he has really dedicated himself to this trial. We have support from the Alpha Stem Cell team, and then, of course, Dr. Mozaffar, our chair of neurology, who really lets me dedicate so much of my time to ALS clinical trials and trying to move this field. But this trial is a really big thanks to the patients and the families that are involved. And it has really given me a new meaning to it takes a village to do something like this, but I now understand what that meaning is. So thank you all for your support tonight.
Sure. So the question was whether we have seen any increase in the number of cases of ALS and people actually have looked at this. And there have been scientific studies that have looked at it, and there doesn't seem to be any evidence at this point that the numbers are necessarily increasing. We've always suspected that our cohort of ALS patients tends to be younger than, let's say, the East Coast, but again, not substantially so. So the numbers haven't increased. It's not getting necessarily any younger. If anything, there is a paper from Dr. Appel in Houston that the number of ALS patients may be getting a little older than what used to be, but there's definitely no increase.
It's really upsetting because they're young
Absolutely, I understand. So the question was, the age cutoff for this clinical trial is 60 years old, but like Dr. Mozaffar said, the average age of an ALS patient is 50 to 70, and we have a family member here who has a brother that's 63, and why do we have to have such stringent cutoffs? Actually, for the phase 2 study, the age cutoff was 55 years old. And when they invited me to participate in this clinical trial, our investigator meeting to design the trial was in Boston. And I flew to Boston and I actually argued with the CEO and I said, our patients in California are healthy. 60 is the new, 40. So I at least upped the age to 60. But it was purely, they knew this trial is a difficult trial because of the 7 spinal taps. And they just know the challenges that can sometimes come with older age, 70, 80. And not all some 70-year-olds are much healthier than 50-year-olds. And I understand I entirely support and understand your argument. Absolutely. And unfortunately, all we could do was increase it to 60. But generally what happens is when the FDA looks at the data, they don't, many times, and I'm speaking from prior clinical trial experience, if the therapy works, they're not going to say, oh no, it can only be used for 60 is a possibility. Insurances may say we have to use clinical trial stuff, but the FDA may approve it for all ALS patients if it works.
Are you taking any more? Or is this
We are still actively enrolling. Yeah, and those are basically criteria that the company and the FDA set. So it's not us at UC Irvine that designed that. But we do have other clinical trials that do not have an age cutoff of 6. Yeah, for ALS, yeah. But they're not stem cells, but they're other drug therapies. Yeah, sorry.
How do you extract the human neural stem cells from fetuses? Because wouldn't it be more difficult to extract them from smaller bodies than, let's say, adult ones?
Do you know that?
So I saw Namita's face. So in this trial that Dr. Goyal is speaking about, these are cells that come from the patient's own bone marrow. And so there's no embryonic stem cells and no fetal stem cells that are derived. What you could be thinking of is in the first trial that was shown, the neural stem trial, those are actually fetal neural stem cells that were used in that trial. And in that case, that's a source of stem cells that comes from abortions. And so these are generated as research donations where a new cell line is developed and then it's expanded and used for a long, long time, just like in the case of embryonic stem cell research. But in this case, it's a completely different beast because it's bone marrow from the individual that has disease. Now, there are problems with that, right? Because that individual has disease. And so it could be that there's a flaw in their cells that mean that their repair is going to be limited. So there's a strong argument to be made that both directions are important questions to ask. We just don't know what's going to work the best clinically in the long run.
And just to signify, so the mesenchymal stem cells or the bone marrow-derived stem cells have limited potential to form into specific cells, whereas the fetal or the embryonic, which is even one step earlier than that, are pluripotent, which can turn into any cells. So the risks are higher because they can turn into a hairball, they can turn into tooth, but they can also regenerate neurons. Okay, so if you look at the first two stem cells Dr. Goyal showed, the neural stem cell as well as the Cedars-Sinai stem cells, those are fetal cells. So they have a little bit more potential. They're still not turning into neurons, they're still supporting the cells, but they have a lot more potential. This is a safer trial because it's mesenchymal. It doesn't require immunosuppression. And what it's doing is it's helping the supporting cells so you can produce more growth factors. And the growth factors is what reduces the inflammation, what keeps your motor neurons healthy. That's the difference.
I have two questions, one for Dr. Goyal and one for Dr. Mozaffar. Dr. Goyal, on the graph that you showed about the growth factors that were secreted by the cells, you showed BrainStorm having a subset of shootings after implantation. Is there any data longer term, longer than 2 weeks, to show whether or not the growth factors are present in a sustained manner? And maybe that's part of what informs the idea of being multiple.
Yeah, so they have not shared the data yet, but there is CSF that was collected in up to 24 weeks that we don't have information on yet. In the current trial, we are actually doing spinal taps every 2 weeks after the first transplant, and then after each transplant every 2 weeks. So that's why the patient gets up to 7 spinal taps. And I think based on this data, they want to collect further information for a biomarker. Yeah.
Thank you.
You're welcome.
And one more question, Dr. Mozaffar. On the multidisciplinary categories of intervention that you showed, there was one item missing that I was wondering if you guys actually addressed, and that's physical activity. Is there anything done with ALS and exercise?
That's a great question. So the simple answer to that is we really don't still have a good answer to that question. So that's a question that we get asked all the time in the clinic, which is whether somebody who has ALS should be exercising or not, and if the exercise is good or bad. Okay. There is a study that was conducted by Nicholas Maragakis at Hopkins that at least showed that this exercise was safe, but it's a small study. What we think and what we recommend to our patients is that they should do simple aerobic exercise, and the simple advice is don't do anything more than what you're used to doing. So if they go into the gym with the expectation that they're going to pump weights and they're going to get stronger, that is not going to happen. They may get a modest 2% improvement in strength, but in the process, they are putting themselves at risk for fatigue. They're putting themselves at risk for eccentric injury on that. So the purpose of the exercise is to keep the muscles going, to keep the muscles active, and hopefully prevent the rate of decline. But at this point, we don't have any data to suggest that exercise necessarily slows down the disease beyond the very modest benefit. But we know that it's potentially not harmful to the patient. But again, it really depends on moderation. Everything has to be in moderation on that. I don't know if that answers your question or not. Yeah.
Inflammation was mentioned as a part of the disease, and it's involved in many diseases. And I gather that cortisone, an anti-inflammatory drug, the side effects perhaps are worse than the benefit to the patient. But would you say anything more about the role of inflammation, do you think?
Sure. So when I was in training about 20 years ago, it was almost a heretical concept that people talked about inflammation in ALS. So when Stan Appel suggested this idea that there may be autoimmunity and there may be inflammation in ALS, he was almost ostracized. Luckily, he persisted. And now we know that inflammation plays an incredibly important role in the disease process. We still don't think it's a primary inflammation. We don't think it's what's causes the disease. But we know, like Alzheimer's, and like that there is a prominent inflammatory process, especially macrophage-driven process on that. And Stan Appel just concluded his study where he looked at T regulatory cells. So these are cells that regulate immune function. And he did bone marrow transplants to upregulate T regulatory cells and showed that you can slow down the rate of decline in ALS. So he's been sort of vindicated in that. I mean, people have sort of, people have accepted. And there have been a number of trials, I mean, including some of the trials that Dr. Goyal mentioned, that have looked at inflammation on that. So Neuraltis's drug of NP001 was one of the trials that looked at that. There are other trials that Dr. Goyal probably knows more about than I do, because she does more than I do on that. But they are very, very clearly looking at that. But in the past, people have tried immunosuppressive. There have been trials on immunosuppressive. There was a trial on total lymphoid radiation that didn't work on that. So people have looked at it periodically, but it has come back full swing, because people have recognized that there is a role of these macrophages and regulatory T cells.
We're currently doing the ACTHAR. And we're currently actually doing another steroid type of drug trial, because this concept has come back that maybe there is an inflammatory role. So one of the drug trials I mentioned is actually using a steroid type drug.
I don't know if you're familiar with a study that was done at the University of Oregon with copper. And what they did was they allowed copper to go into the bloodstream. And what it did is it slowed the progression of the disease down, but they only did it in mice. And as soon as they stopped the copper, the disease progressed rapidly. Are you aware of any of that type of study?
So again, I'm not specifically aware of that particular study, but we know that there are individuals who get acquired copper deficiency. So copper deficiency is like the new B12 deficiency. So there are a number of individuals who are either not absorbing copper, or they're taking zinc supplements, which has become really popular, especially amongst the elderly, because it's supposed to be an immune booster, which compete with copper absorption, and these patients get low on copper levels. And some of those patients presented like an ALS patient. They presented, so we look for copper in all of our ALS patients as one of the features in that. But I'm not particularly aware of that study. And again, I'm not surprised, because copper deficiency will create something that looks like ALS. And you can potentially slow it down by supplementation of copper. So it makes logical sense. Dr. Robertson, did you have?
Yeah, so these bone marrow cells are injected into the spinal fluid. Where do they go with it? Do you have any idea? Are they locally situated? Do they go elsewhere? Where do they go?
So I asked if BrainStorm, the company, had collected any autopsy data from the prior study, if any of the patients had passed away, just to see if we know from brain pathology or spinal cord pathology, if we could see anything that was different from the placebo group. They have not. But theoretically, we know that the spinal fluid goes throughout the brain and the spinal cord. But I'm not sure if there's more to that. So
not specifically for the neuron stem cells, but Tony Windebank at Mayo Clinic had done his own stem cell trial where he had engineered the stem cells. These are mesenchymal stem cells as well. And what they had done autopsy tissue, and what they had shown that these stem cells essentially lined the thecal space and produced growth factors. So again, we don't have that data for the stem cell, the BrainStorm trial, but at least looking at Tony's work, Tony had shown that they lined the ependyma or the thecal space and produced the growth factors.
And they lived?
They lived, yes.
For?
I don't know how much of a long-term data did Tony have. I don't. And he's one of the sites for this trial as well. So.
Hi. It's been a great talk, and I enjoyed all the slides. In your presentation, there was when you compared the placebo as well as the stem cell, there was this kind of the 1.5, the points. I just want a little explanation of that.
Yeah.
And as to the functional improvement in the patients, and it's kind of great to see that patient on the video. But how far do you go beyond the 28 weeks that is, it's already completed? How often are you bringing back the patients to see the functional improvement? I mean, I'm more interested in understanding that, not only just the micro level as well.
So just to answer your first question, that analysis gets a little bit confusing, and when I had seen it for the first time, I was trying to wrap my head around it. But what's important to know is that ALS functional rating is scored on a standardized scoring sheet that has been developed as a clinical trial tool as an outcome measure. So the function is graded from speech, swallowing, walking, using hands, breathing, on a 48-point scale. And through natural history studies, we know that the average ALS patient drops by 1 ALS functional rating point every month. But what this study did was it did not use the natural history. If you remember it, I talked about the 3-month observation period before the trial, before the injection start. So the patient is enrolled in the study, but every month we do an ALS functional rating score for them, and we keep that rate of decline. Then the study did the same thing post-treatment. So it's basically the post-treatment over the pre-treatment slope. And that rate of improvement is what translated to 1.5% improvement.
So you're making great progress in finishing this trial. If money was no object, what would you do next?
Well, I think this trial will still have many unanswered questions, right? Is the dose correct at every 2 months? Do patients need every 2-month dosing? Is there a period where we can say, oh, the stem cells have taken over, we don't need to treat again, one treatment was enough? Or does it need to be really repeated I think answering a dose question would be very important for patients in terms of how long will the stem cell therapy actually work if it is a positive trial.
And Sid, the neural stem cell phase 3 is held up right now because they can't get enough investment into it. So if you have a pot of money, I'm definitely going to ask Neural Stem to look at it into it as well. Okay.
Dr. Mozaffar, you mentioned that injecting a diseased person's bone marrow into their spinal fluid may be harmful. Some people, I've heard that they donate bone marrow. Is it a possibility to use somebody else's bone marrow?
Do you want to answer this?
Yeah. So I think the biggest concern that happens with injecting someone else's bone marrow is that it then starts being considered an organ transplant, which is something where you worry about, would the body take it, accept it, or would the body say, what, this is a foreign product and I'm going to reject it? And to try to counter the rejection, a lot of times in medicine we use chemotherapeutic agents, but the challenge in ALS is patients are rapidly losing weight, they're losing muscle mass, and then if you add another third component, like a chemotherapeutic regimen, that sometimes can make them nauseous, can make them lose their appetite, they tend to lose weight and progress even faster and be sicker in a more rapid fashion. Does that answer your question? Okay.
So I do want to make a public service announcement as well. So there are a lot of shops in the county that are offering stem cell treatment. They don't call it trial, they actually call it treatment, and they call it cure. And what they're doing is that they're taking fat cells from, let's say, a liposuction, and they're directly injecting it into whatever disease they think that they're trying to treat. These cells have not been treated to any special reagents. They have not been processed. They have not been harvested. And this is nothing more than quackery. Okay, there's a lot of work that still needs to be done. It needs to be done in a scientific way. It needs to be done under scientific rigor and with careful attention to side effects, to the harm that we may potentially be causing to the patients. So again, it's available. Some places are charging up to $60,000 for this. It's completely unethical, completely wrong. And I just want you guys to be aware of it. And I think Eileen is.
So this is a man after my own heart. So I can't resist jumping in on that. So this is such an important issue. There are some great resources out there. We're actually in the process of adding one onto our website here as a resource for patients and just community members. But on top of that, we're formulating a sort of continuation of this series, and Dr. Cummings is going to be giving a lecture. Do you have your date? March 28th, that we have specifically added on this topic. So that will also be up on our website for reference once Brian does it. But it's an extremely important topic. It's why CIRM has created the alpha stem cell clinics. These are something that is set apart from what I don't have a better word for than quackery. And come to Brian's lecture because I think it'll be very informative. I did see one, oh, there we go.
My wife and I attended a lecture here at UCI last week, and it was called Body on a Chip. You're familiar with it. I was wondering, it said, he used basically the same slide that you used, which showed 10,000 items being looked at and approved by the NIH or somebody to say, or the FDA, to say that they could go down to the 250 that wind up going into trials. What I got out of his talk was that that was going to speed up the number of things that could get into the trial mode, or very, very much expedite it. Will that have an impact on stem cell therapy trials?
So I'll field that one and give these guys a rest. So this is Dr. Chris Hughes, who's actually also a member of the Stem Cell Research Center. And he's just ending his term as chair of molecular biology and biochemistry on the other side of campus here. What he's developed is a 3D organ tissue engineering body on a chip, organ on a chip, where he can model the blood-brain barrier and using stem cells, using all induced pluripotent stem cells, so that he has a human model of how drugs can cross the blood-brain barrier and access the spaces that are critical to be able to do drug delivery for neurological disease. In that valley of death image that I showed, this is a huge gap. Things that work from a pharmacokinetic perspective in mice and rats don't always move up the chain very well to translate into humans. And so what Chris's technology does is really bring a new way where we can use human model cells to test delivery across the blood-brain barrier, but also to make mini organs, a kidney, a pancreas, right, where the blood-brain barrier is very important in terms of gating, and model the effects of drugs on not just stem cell populations, but using stem cells as a tool to be able to do more efficient pharmaceutical design. Does that make sense?
It should help the ALS studies.
Should help the pipeline for lots of things.
Thank you.
So I think maybe on that note, I'm sure that our speakers will stay put for a few minutes.
So you're welcome to come up and ask questions afterwards, but we're going to shut down the formal part of this.
Yeah.
I was texted by a colleague. This number is not live. This is a static slide, but we've raised over $150 tonight. If you're a high school student, we don't expect you to donate, but you can still text UCI stem cell to 41444. You'll get a ding back. It won't charge you anything. Show that ding to your parents, and just like they do PTA stuff, they can donate instead. But thank you all for coming, and you're welcome to come on up and chat with our people.